Madam, we can start now.
O- Okay, sir. A very good morning to everyone. Myself, Jasleen Kaur, Assistant Professor in the Department of Pharmacology at Amar Shahid Baba Ajit Singh Jujar Singh Memorial College of Pharmacy, Bela. I feel truly honored to serve as the host for today's expert lecture and will be guiding you all throughout the session. Today's expert lecture is being organized on the special occasion of 51st Golden Jubilee celebration, a milestone that marks over 5 decades of excellence, growth and academic legacy. Before we begin, I would like to take a moment to introduce our esteemed institution, Amar Shahid Baba Ajit Singh Jujar Singh Memorial College of Pharmacy, Bela, which is one of the premier institutes of Northern region. It was established in 1993 by a non-profitable society in the sacred memory of Sahibzadas Ajit Singh Ji and Jujhar Singh Ji, the sons of Guru Gobind Singh Ji, who sacred their lives at a very young age. This institute has made remarkable progress over the last 3 decades and offer various programs including Diploma in Pharmacy, Bachelor of Pharmacy, Master of Pharmacy, MSc Pharmaceutical Chemistry, MSc Microbiology, and Bachelors in Medical Laboratory Science. An autonomous institution, COPBELA, is affiliated with IK Gujral Punjab Technical University, Jalandhar, and is also a recognized PhD research center in pharmaceutical sciences. The college is accredited by NBA, recognized under UGC 2F, ranked 57th in NIRF 2024, and placed in platinum category in AICTE CII Industry Linkage Survey 2018 and 2019. With great pleasure, I introduce today's expert speaker, Mr. Kuldeep Kumar, working as an assistant professor in the Department of Pharmacology at Guru Gobind Singh College of Pharmacy, Yamuna Nagar. He earned his MPharm in pharmacology from Chandigarh College of Pharmacy and is pursuing his PhD at Punjabi University, Patiala, with collaborative research at AIMS, New Delhi. His doctoral work focuses on the role of adenosine and cannabinoid receptors in cardioprotective mechanism. With nearly a decade of academic and research experience, he has served at several reputed institutions including Punjabi University Patiala, Chandigarh University, Mohali, and AIMS New Delhi. He has authored more than 28 research and review articles in peer reviewed journals of high impact, including Biomedicine and Pharmacotherapy, European Journal of Pharmacology, Molecular Neurobiology, etc., and contributed more than 8 book chapters in edited books in the area of cardiovascular pharmacology, neuropharmacology, and Springer Nature, Apple Academics Press Publication House. He is also a reviewer for leading the international journals such as Cancer Medicines, currently Cardiology Reviews, Pharmacology uh, Research Report, and Frontiers in Neurobehavioral Neuroscience. His contributions have been recognized with honors, including the Professor O.D. Gulati Award for the best work in cardiovascular pharmacology at Annual Conference of the Indian Pharmacological Society 2024, held at AIMS, New Delhi, and the Best Researcher Award by INSO Award 2022. We are truly delighted to have Mr. Kuldeep Kumar sir with us today. On behalf of our college and all the present here, I extend a very warm welcome to you, sir. Now, without further delay, I would like to invite Mr. Kuldeep Kumar sir to kindly deliver his lecture on the topic pharmacovigilance, ensuring drug safety for the better health.
Thank you very much, ma'am, for a nice introduction about me. So, firstly, before I move further, I would like to congratulate to the governing and managing body of Bela College of Pharmacy, as well as to the director and principal of Bela College of Pharmacy for achieving this milestone of 50 years of establishment. And I would like to thank to the organizing chair for making me the part of this Golden Jubilee celebration. So, without further delay, I just like to start my talk, which is entitled "Pharmacovigilance: Ensuring Drug Safety for Better Health." Shall we start, ma'am?
Yes, sir.
Okay. I would like to start my talk with this particular some facts and figure which we might not be aware of. So these figures are, as it is already documented, that around 35% of the hospitalized patient experienced an adverse drug reaction. It could be anything, whether it could be rashes or any other adverse drug reaction. And around 3,50,000 patients of hospitalization, they only occur due to the ADRs. And after cancer and cardiovascular disorders, this is the fourth leading cause of death around the globe, and around 1 lakh patients die every year due to adverse reactions. So, this much of dangerous it is. So, now this is a very good talk, quote. Dying from a disease is sometimes unavoidable, but dying from a medicine is really unacceptable. This is really true. If any person die due to any disease, then his or her guardian will accept it. But if anyone is dying due to the intake of medicines, it will not tolerable. So therefore, this pharmacovigilance is very, very important for us. So now I would like to touch just a brief overview. What is pharmacovigilance actually? This is basically combination of two words, which is drug as well as vigilier. So pharmacon and vigilier. This pharmacon stands for, which means any drug or any other chemical which is exogenously administered. And vigilier is always to keep aware, to keep watch. So this is the basic definition which is being given by the WHO. So this pharmacovigilance science, this is a branch of pharmacological sciences which is related to these particular terms, which is collection, detection, assessment, monitoring, and prevention of all the adverse drug reaction which is related to any pharmaceutical products. So this is the definition which is given by the WHO. Now, question arises why it is needed. Why do we need pharmacovigilance? So there are some facts. It has been suggested that around 5,700 deaths in United Kingdom was occurred in the year 2004. And this was the fourth to sixth commonest cause of the death in 1994 in United States of America. There are some other aspects why we need it. One is humanitarian aspect due to inavailability of the sufficient data about the safety of any drug, due to lack of clinical trials, due to lack of animal experimentation regarding the specifically toxicity of the drugs. And there are, it is also documented around 7 to 800 bad patients, bad hospitals are also occupied by the patients who are suffering from any kind of ADR due to any drug. So this is just a repetition of the previous slide, which is in touch. There are some humanitarian aspect. We have to take care of the patient. So that's why we need pharmacovigilance. Next is ADR may cause sudden death. Definitely, it is really true. So any adverse reaction, it may cause sudden death of any patient. So therefore, it is needed. Therefore, it is needed to monitor and control. Next is promoting the rational use of medicines and adherence. We have to promote the rational use, we have to promote the relevant use of the medicines, and we have to adhere with that guidelines. Next, very important aspect is some ethical aspects. It is already told that ADR is not harmful to the other person, but they are really, really harmful. So it should be, we should adhere with these guidelines that is documented by the pharmacovigilance department. Now, the important thing is what are the basic objectives of pharmacovigilance? There are four major objectives. First is patient care. So this patient care basically helps in the improvement of the patient safety as well as the of the care of the patients. So therefore, this is very, very important. Second is it is very important for the early detection, or you can say it is very important for the public health. So early detection, if we detect any ADR related to any drug, detect early, then we can resolve the problems. So say safety problem is a major concern. Next is risk benefit management. We should calculate what are the risks with that particular drug which we are taking, and what are the benefits. If the risks are more and benefits are less, we should not take that medicines. And if benefits are more, risk is less, then we should be continued with that. And next is communication. Just to tell the people, to tell the medical professionals that what is area and how you can assess that. We should train to the health professionals and public also about the awareness of the adverse reactions. Now, what are the basic outcome when we take any drug? There will be two kind of outcomes. First is desirable therapeutic effects, and second one is undesirable adverse reaction. Desirable therapeutic effect is always means that these are the indications why we are taking. Suppose we are taking diclofenac, so it's a painkiller. So that is a desirable effect. So indications is a desirable, and it is always mentioned in the folio which is inserted in the box of that medicines. But there are some undesirable effect which is termed as adverse drug reaction, and they are unfavorable and unintended. Normally it is not mentioned in the folio of the medicines. Now I would like to touch some basic classification of adverse drug reactions. There are majorly six type of classes which we have to deal with under ADRs. First is type A, which is dose related and expected. They are always expected. It is already documented that this much of dose, if we take of any drug, then this kind of ADR will be experienced. So this is always dose related. Extension, this is basically happening due to the extension of the pharmacological effects, or you can say pharmacological activity. Best example is salbutamol. It is a beta 2 sympathomimetic, but it causes tachycardia. Next side effect we have is type B, which is not dependent on the dose. It is also known as bizarre side effects, and they are very serious as compared to the type A side effects, like JH reactions and rashes, which occurs due to the penicillin intake. Next, we have is type C, that is dose as well as time related side effects. So, what happens when we are taking any compound for the longer time? So, there will be the accumulation of that particular drug, and this cumulative accumulation of drug will cause a side effect. The best example is NSAIDs, which is non-steroidal anti-inflammatory drugs. They induce nephropathy. Why this is happening? There is a reason, because this NSAIDs actually acts by the inhibition of the cyclooxygenase. So this cyclooxygenase, what it does basically, this basically helps in the synthesis of the prostaglandin, leukotriene, and thromboxanes. So here we will talk about only the prostaglandin. And this prostaglandin, as we know, prostaglandin plays an important role in maintaining the blood flow to the kidney. So if we give NSAIDs for the longer time, what will happen? Cumulative dose will be there, and this will start inhibiting the prostaglandin synthesis. Once it is inhibited, it will further impair the blood flow to the kidney, and it eventually causes nephropathy to the patients. Next, we have is type D, which is delayed type of reactions, and they basically occurs after 3 to 4 years of intake of any drug, and it includes carcinogenicity and teratogenicity. Carcinogenicity is the this is the occurrence of cancer due to any drug, and teratogenicity is the best example is thalidomide and phocomelia. So this we will discuss in upcoming slide in detail. Next, we have is type E, which is end of the use. When suppose we are taking any compound, the best example is steroid. If you take the steroid like prednisone, hydrocortisone for the longer duration, and suddenly if you withdraw intake of that compound, then you will having some withdrawal effects. So the best example is steroidal withdrawal leads Addisonian crisis, or you can say Addison insufficiency, adrenal insufficiency. What happens in this basically? When you start discontinuing the sudden intake of that steroids, what will happen? Your body will not adapt the secretion of cortisol from the kidney. So that basically affects your, you can say, functioning of your adrenal gland, and that basically eventually known as adrenal insufficiency. Last we have is failure of the therapy. This is also very important. Sometimes doctors misprescribe the things, doctors misdiagnose the things, misdiagnose any kind of disease, and they basically select the wrong medicines. So that also can lead any kind of ADRs. So doctors should also always have to take care of the patient history. He or she should also always know about the what kind of medication he or she is taking already. So on the basis of that, he or she should prescribe the further medicines. Next, we have is what are the basic sources of adverse events reports. There are two kind of sources. One is solicited reports, and second one is spontaneous report, or you can say unsolicited report. So solicited reports are basically clinical trials. So as we all know, there are 4 or 5 phases of clinical trials, and basically in post-marketing phase, that is a very important observational study which reports the ADR on larger number of population. So these are the solicited reports. And in unsolicited cases, unsolicited reports, there are patient support programs, several patient support program we can launch. Next, disease management. Next, market survey. We can survey the market. We can go to the door to door for just knowing about the area of any particular drug. Next, some documentation like registries are there. Pharmacoeconomic studies in any kind of particular population, you can study the that particular area, and quality of the life questionnaire. So these are the some unsolicited documents. This is very important. This is a very famous example of adverse drug reaction. Now I'm going to touch some examples of adverse drug reaction. This is the thalidomide disaster we all must be aware of. So it happened actually in the back in the 1957. So, what was happening there? This thalidomide was being used as a over-the-counter medication by pregnant females to manage their morning sickness. So later on, they came to know the baby which is the baby which is surviving in the womb of the pregnant female, they are suffering from a very serious side effect, that is phocomelia. Around 20,000 baby were affected that time, and it was spreaded around 46 to 50 countries. So later on, they came to know that it is causing phocomelia, which is seal-like limb, or you can say abnormal development of the limbs. So it was laterally discontinued, and it is not being used nowadays for morning sickness. The another very important example is Vivox, which is the marketed preparation of Merck Pharmaceuticals. And basically, it is due to the rofecoxib, which is a you can say coxibs, which is NSAIDs, preferentially as a COX2 inhibitor. Rofecoxib is there, celecoxib is also there. Celecoxib is not discontinued, but rofecoxib is already discontinued. In the year 2004, there was a serious cases of heart attack, and eventually it led death of the patients. Around 38,000 people died due to the intake of this particular compound, which is rofecoxib. Next, very good example. It basically happens only in the Bangladesh. So this is also famous with the name of paracetamol tragedy in Bangladesh. Actually, what happened? There was a pharmaceutical industry, which is Adflame pharmaceutical industry. They formulated the paracetamol syrup, adulterated paracetamol syrup. And after the intake of that adulterated paracetamol syrup, around 76 children died in the back 1990s. And another pharmaceutical industry was Reed Pharmaceutical. It also caused same effect in the year 2009. Around 30 children's died due to intake of this paracetamol. And this was a very important highlight of the newspapers of the Bangladesh in Dhaka Tribune also. Next we have is now the question arises how we can report. Till now we have studied what are the areas, what are the types of areas, what kind of areas we can have, what how we can report. There are three basic ways. By telephonically you can report, to whom we have to call, that we will discuss in the upcoming slide. By email you can report, and by putting in SMS you can report. What to report and when to report? You suppose today you have start facing any kind of ADR. So within next 24 hours, you have to tell to the NCC, which is National Coordination Center of India, to the about your ADR which you are experienced due to any drug. Now this is who to report. Who are the persons who are responsible for taking care of these all the things? First, patient are very first person who can report the ADR. Next, doctor. If any patient is suffering from ADR, he or she should go to the doctor and tell to the doctor that I am facing this kind of problem. Doctor are the responsible for reporting the ADR. Other medical advisory team, they are also reported. They are also responsible for reporting ADR. Next, other medical staff like nursing staff is there. Any other supporting staff who can report, and MIO, which is Medical Information Officer. they are also legible to report the areas of any drug. Now, the question arises, what we have to report? Who to report is done, when to report is done, and now what kind of details we have to report about about the area. First is patient details. Whenever we are reporting, whenever we are filing any case of ADR, we need to report these four things. First is name of the patient, what is the gender and what is the age of that particular patient. Contact details, obviously we have to report, and the special condition, whether the if patient is female, whether he or she, whether she is pregnant or lactating mother, then that particular condition we have to report. Next we have is reporters detail. Who is actually reporting? Whether it is a doctor, whether it is a medical information officer, whether it is any other medical staff, that is name should be there. What is the occupation of that particular person, and what is the organizational address and contact details. Next we have is adverse event. What was the time, what was the date of onset? That is very important. When he or she has experienced that area, what are the symptoms, whether he faced any kind of rashes, urticaria, angioedema, or any other hypersensitivity reaction. Even it includes some kind of fevers, any kind of other symptoms which is experienced by the patient, that we have to report. And what are the outcomes? Once he or she felt the ADRs, felt the symptom, what was the outcome? What was the basic outcome? And what are the seriousness, whether it is a mild toxicity, whether it is a moderate toxicity, or is serious toxicity. So these kind of event we have to report. Next, about the suspected product. This is also very important. Although this is not being reported by the manufacturing industry. So what is the brand name? Which medication he or she has taken? Next, what was the dose and frequency? How many dose? What was the dose? Suppose it is 100 mg. How many times he has taken? Two times, three times. What was the route of administration, whether it is taken orally or any other route? Batch number of that particular uh, uh, batch is which is mentioned on the, you can say, box of the medicine, that we have to report. And what was the medical history of that patient, whether it is any kind of special history or he was a normal patient. Next, this is very important. There are some myths and facts. These are the some myths, that all the ADRs are documented by the time of the drug is marketed. No, it's never reported, because it's a huge loss of pharmaceutical industry. They will never report the particular area for any drug. Next, uncertainty about the causality. This is also a myth. Next, one report cannot make a difference. Uh, it is a myth that one report cannot make any difference. Yes, definitely, if any serious ADR is there, like thalidomide digester, if it is being reported, if it is being reported earlier, then definitely it can make a difference. We can save the 20,000 childrens. Next, ADR should only be reported if certain, and known side effect should not be reported. So these all are the myth which is not being done by the followed by the pharmaceutical industries. Now, why the question arises, why there is under-reporting? Why the people don't want to report anything? First, very important reason is workload. This is especially applicable for the private organization, as we all people are working in the private organizations. So a lot of workload is there. So we are not much aware of the things that I am feeling this kind of ADR. So I would not like to go for the reporting of ADR, because it is a hectic process. Next is uncertainty about the causality. Next is unsure of the useful of information. Means sometimes we are not aware of the therapeutic application of any compound, and still we are facing any kind of ADR. So that is also a major reason of underreporting. Next, lack of awareness. We are not much aware of the ADR of any kind of drug, and age of the molecule. If the molecule is very aged, or you can say it's if it is very old, then it can lead to the ADR. So these are the several reasons why the underreporting is there. Now, this is a very important slide. Pharmacovigilance, how this pharmacovigilance department works actually. The first data will be collected. The first step is data will be collected in the form of ICSR, which is individual case safety report. So this data will be collected by the person who have already discussed in the previous slide. So this data will be entered in the database. Once the data is entered, then this data will be processed by AMC, which is ADR monitoring center of that particular region. Suppose we are living in India, and in the northern India, you can say PCI Chandigarh is the major department who is monitoring the area. So we have to submit that case report to the AMC. Now, once it is submitted to the region head, then it will go to the NCC, which is National Coordination Center. It will go to the national head. Then further, if it is assessed by the NCC, then finally it will be submitted to the two regulatory authority. First, it will go to the Indian authority, that is CDSCO, which is Central Drug Standard Control Organization. And once it is assessed by the CDSCO professionals, then it will be submitted to the UMC, which is Uppsala Monitoring Center, Sweden, which is located over there. And this is the head department of across the globe who is responsible for monitoring the ADR, who is responsible for controlling the ADR and taking some necessary action for prevention of the ADRs. Now the question arises, there are some softwares which are basically applicable in management and reporting of the area. The major software is VGFlow. This VGFlow is actually the web-based system to report the ICSR, which we already discussed. This is a management system which is specifically designed for the use of national center in the WHO program for the international drug monitoring international drug monitoring. And the version which is being used is VGFlow 5.1. It is an old data, although. Next, some other tools are also there. And very important part is this VGFlow subscription is free for India. You don't need to pay anything for this for getting subscription of this particular software. Next, there are some other tools, Arise, but this Arise is specifically only used for the European countries. Next software we have is Argus, which is being used in the United States of America, and another one is VGBase. This is also prevalent in the United States of America. Now, this VGFlow reporting system actually works. Once the ICSR is there, once anyone has filed this individual case safety report, it will be uploaded in the database of the VGFlow. Then it will be reached to the AMC, which is ADR Monitoring Center of that particular region. Then once it is uploaded over there, it will be received by the National Coordination Center of suppose we are talking about India, so it will be received by the either PJ Chandigarh or either IPC Ghaziabad. Next, once this is reached to the NCC, it will be assessed by the NCC professionals whether it is okay or not. If it is not okay, if the reporting is not complete, then it will be sent back to the reporting agencies. If it is okay, then it will be conveyed to the CDSU headquarters, and finally it will be gone to the Uppsala Monitoring Center, Sweden. This is again the framework of pharmacovigilance. So I'll just brief out. There are some peoples who are actually responsible for reporting the ADR, which we already discussed. Doctors are responsible, pharmacists are responsible, nurses are responsible, some other consumers or other medical professionals are responsible for reporting the ADR. So what will happen? They will report about the sorry. They will report about the side effect or any kind of symptoms, special symptoms which where they are experiencing. It will be reported. Then this data will be collected and evaluated, which we already discussed in the previous slide. Once this is assessed, then it will be submitted to the CDSCO, and finally it will be reached to the Uppsala Monitoring Center, and then it will be decided, final decision will be taken over there, whether there could be any particular decision, whether that package insert amendment should be there. Means to say, we need to we need to add some important guidelines about that particular product in the folio of that medication, or there should be any warning mentioned, and schedule changes. Means we need to change the schedule of intake of any drug. Next, risk management profile we should manage, and market withdrawal. This is a very important decision of Uppsala Monitoring Center, because it can cause the huge loss to the pharmaceutical industry if we withdraw any marketed compound. So this is how this pharmacovigilance department actually works. Now, I would just like to touch some important brief history. What was the actually establishment of pharmacovigilance department in India? So it was basically started in the back 1982 until 1989. ADR Monitoring Center was established. Total 12 regional center was established till 1989. Later on in the 1997, India actually collaborated with the WHO, and they also, you can say, established three other monitoring center. It was in the Ames, Delhi, and it was in KEM, which is King Edward's Medical College, and JLN, which is Jawaharlal Nehru Medical College. And in the later 2004 to 2008, some national pharmacovigilance program was started by the India, and later on it was joined by the IPC, which is Pharmacovigilance Program of India. It was full flash established in the year 2010, and nowadays it is being governed by the PJ Chandigarh as well as Indian Pharmacopoeia Commission, Ghaziabad. Next, this is again the brief history of PBPI, which is Pharmacovigilance Program of India. India joined this program in the 1997, as we already discussed, and in the 2004, National Coordination Center was established. Then, in the year 2010, this National Coordination Center, it was shifted to the Indian Pharmacopoeia Commission, Ghaziabad, in the year 2011, and nowadays it is being it is being regulated by the IPC Ghaziabad. So this is very, very important. How we can report? There is a mobile application which is EPVI, which is termed as Electronic Pharmacovigilance Program of India. Actually, Government of India, in collaboration with the you can say Ministry of Health and Family Welfare and IPC, they launched a mobile application. This mobile application is applicable and it is available on the Play Store. So you can directly just log in it, and you can register yourself, and you can report any kind of area through this particular mobile applications. This is very, very important. This is a very good step of India. Next, these are the some examples, drug withdrawal due to any serious ADR by the US FDA. The first is phenacetin in the 1983. It was withdrawn due to the risk of cancer and kidney disease. Next is methaqualone. It was in 1984 due to the risk of addiction and overdose of the medications. Next is norepinephrine. This was causing hemolytic anemia, and it was withdrawn from the market in the 1986. Next is troglitazone. In the year 2000, it was withdrawn, which is the anti-diabetic medicine, and due to the risk of severe hepatotoxicity. Next is rofecoxib, which we already discussed in the year 2004. It was withdrawn due to the tachycardia, or you can say myocardial infarction. Next, we have is, these are few other examples. Thalidomide digester, which we already discussed. It was being used for by the pregnant females for the management of morning sickness, but nowadays it is used for management of myeloma, multiple myeloma. It is being used for the management of leprosy as well as multiple myeloma, but it is strictly restricted to use by pregnant females for management of morning sickness. Next is lysergic acid. It was causing some psychiatric symptoms. That's why it was withdrawn. Diethylstilbene, fenformin, which is a very famous anti-diabetic compound, and lactic acidosis. Serious side effect is there. Lactic acidosis was there. That's why it was withdrawn from the market in the year 1978. And there are some other drug like jamilidine. This was also causing the particular symptom, which is Guillain-Barré syndrome. So this was all about pharmacovigilance from my side. Thank you very much.
Thank you so much, sir.
Thank you very much, ma'am. If
As
any
we,
question is there, then I'll be happy to answer.
sir, every topic is clear. So you beautifully explained the topics, all the
Thank you.
topics: pharmacovigilance, its need, ADR, how PV works.
Actually,
Uh,
it was very brief lecture. Actually, it was told to be I had to take only 30-35 minutes. So
yes,
actually, I concise the topic, and it is very elaborate topic.
yes,
So
sir.
this was actually brief,
But
not much good.
No, sir, but you beautifully connected them to the real world examples. So
Yes.
this truly enhanced our understanding.
Thank
So
you very
thank you
much.
so much, sir, for sharing your valuable time, knowledge,
Thank you,
and
ma'am. Thank you.
expertise with us.
Always
Uh,
welcome. Very much.
yes, sir. Sir, I would like to also extend my gratitude to Dr. Salih Sharma, sir, the
Uh,
director of our college,
Sir is
for
available or not? I
sir.
like to
Sir
talk
is
with him.
not present here, sir.
Okay.
हाँ जी sir. Uh,
Okay.
so
So please give me give him my wishes.
okay sir.
I would like to wish him good morning.
Okay sir. Sir जरूर.
Okay.
Okay
So
sir.
if anything else, ma'am,
Sir, nothing sir. Now I
so shall we
stop the
leave?
live streaming.